We'll move ahead with the next talk. We have with us Dr. ROHIT SAXENA. He actually doesn't need any formal introduction. He's so well known to all of us. But just to complete formality, he's a very well known national, international figure, professor of ophthalmology at RP Center, AIMS. And it's a pleasure for all of us to have you. He'll be speaking to us on the management of third nerve palsy, a tough scenario.
Thank you, Virendra. Thank you very much, and thank you, AIOS and Andhra Pradesh Ophthalmological Society for the opportunity to present here. I'll just give you a brief overview of managing third nerves, which can be quite a challenge, and I have no financial interests, unfortunately or otherwise, to disclose. Complete third nerve palsy can be quite a challenge, and it's because essentially 4 of the 6 muscles rotating the eye are affected. But still, over the past few years, we've had some increasing options being developed. Among them, of course, we know the maximal or supramaximal recess resect procedures of the ipsilateral, that is the involved or the other eye, the lateral rectus periosteal fixation with the large medial rectus recession, a medial globe anchor of, along with a large lateral rectus recession, and of course medial transposition of the lateral rectus, which is now a fairly popular and world over practiced in surgery. So incomplete third nerve palsy, where you have some eye function of the medial rectus. So wherever there is some adduction that you see, the eye is crossing the midline, you know that there is some function to the medial rectus. We'll plan for an ipsilateral supramaximal recess resect procedure. Remember, we are talking supramaximal, that is more than our conventional committant surgery decision making. So the limits that we discuss for committant surgery would not be applicable here. We are talking about an incommittant squint, so we are not worried about incompetence because we know that will exist. In a committant strabismus, we have limits because we don't want to create incompetence and have a patient complain of diplopia, say, in the lateral gazes. That is why we have those limits that we have. So ipsilateral recess resect procedures will give you fairly good correction in the primary gaze, would also help you to retain the motility that you have and be good for it. The other option is sometimes in partially recovered third nerve palsies, you have some element of aberrant innervation, like the medial rectus fibers getting misdirected or going to the LPS. So you have on attempted adduction a bit of lid retraction. Now, this can be used if the patient is willing. When you operate the other eye, you create what is a fixation duress, and based on that, along with the primary gaze correction, like in this case, it was a right third nerve palsy with an aberrant innervation. We operated the supramaximal recess resect procedure in the left eye, and we got the correction of the deviation along with the correction of the ptosis. So the aberrant innervation can be used. Remember, when you're operating the other eye, you need to do as much amount of surgery in the normal eye as you would have planned for the affected eye, because the angles or the muscles are abnormal, and that's what you need an additional innervation to get that alignment. So in incomplete third nerve palsies, you have these options available for you. However, when you have complete third nerve palsies, the challenge becomes much more because you've only essentially 2 functional muscles to look at, the lateral rectus and the superior oblique. A lot of people have tried the superior oblique transposition to the medial rectus. Unfortunately, our results have not been too good. We do get some abnormal features, and because the muscle still doesn't learn that it's supposed to work like the medial rectus, so the superior oblique works like the way it should, and we have abnormal eye movements. So among the other options would be to do a lateral rectus anchoring to the periosteum of the lateral orbital wall. So the large abducting force of the lateral rectus is removed from the equation, and then you can do a medial rectus resection and get some degree of alignment. Now, this is useful with poor but not absolutely absent medial rectus function. So in this case, you can see that the eye in adduction does move to a small extent. So the eye is moving here to in adduction, but it's not crossing the midline. So in this case, we did the lateral rectus periosteal fixation with a large medial rectus resection. You could get a fair amount of primary gaze alignment. So horizontally, the eye was corrected. Unfortunately, if you see a patient, like in this patient, there was no medial rectus function. So in a case with very poor or nil medial rectus function, trying this can be disappointing because the medial rectus has no function at all. So it's just like tightening a rope, and over time it just extends and goes back, and therefore you will be back to the residual exotropia. The other options are the globe fixation procedures on the medial side. There are a lot of globe fixation procedures that have been described, and I generally prefer to use the pre-caruncular approach because this gives us a very fast, rapid entry. The other advantage of globe fixation procedures are that you haven't actually operated on any muscle. Of course, we combine it with a lateral rectus recession. So you've just done one lateral rectus recession, which is essentially necessary in a third nerve palsy management, and done the medial anchor. So you've actually not changed the vascularity of the medial rectus. So this is the approach which I use, the pre-caruncular. The moment you open the pre-caruncular approach, you just get to the medial periosteal wall, and from there you tie non-absorbable ethibond sutures, that what we use. We bring out these sutures from adjacent to the medial rectus and we just tie them right next to the medial rectus. So this is one of the patients which we had operated, and you can see very good primary gaze alignment. Obviously, there is not enough motility, so you don't get too much motility with this. The new kid on the block, or something which now world over is being talked about, is the lateral rectus transposition to the medial side, or the NSLRT. And again, this has been fairly old in description, but recent in revisiting, and a lot of discussion has gone on. Dr. Gokigit from Turkey and had actually revisited it and talked about it, and essentially there was this shortcoming in that procedure, that it left a little bit of residual. So we modified it, and we started, while transposing the split lateral rectus to both sides of the medial rectus, we added a posterior fixation suture, which gave us a lot of very successful results. The important thing that you can see in this CT is that you need to split the lateral rectus far back, almost 18-20 millimeters far back, so that it comfortably wraps around the behind of the globe and does not cause compression there and causing edema. So this is one of the patients of the surgery. I do a posterior tenectomy of the superior oblique along with this, because it not only helps in removing the abducting force, but also allows for movement of the superior split end of the lateral rectus underneath. Again, another patient gives very good long-term outcomes in this. When you have vertical deviation along with a large horizontal, you can actually transpose the whole muscle from the opposite side. So in this, there was hypertropia. So the entire lateral rectus was shifted from inferiorly, that is inferior, underneath the inferior oblique, inferior rectus, to the medial rectus. Again, brought straight vertical and fairly good horizontal correction. I'll just take a couple of more slides, just images actually. This is again a child with hypotropia, the exotropia. We transpose the lateral rectus from the superior root. Again, you can see a good correction of the vertical deviation. Because these were fixed transpositions, we look to try and make them adjustable. The two splits were crossed over from underneath the medial rectus. So this was the inferior slip being sutured superiorly and the superior slip being sutured inferiorly on an adjustable. So I use the short tag noose to make them adjustable, and again this gives you great correction, and you can also titrate a little bit of residual hyper or hypo. Again, another child with mild vertical, you can see in the preoperatively position where it was adjusted intraoperatively and corrected. So essentially summarizing, we have increasing options. See whether it's complete or incomplete, how much there is function of the medial rectus, is there any aberrant regeneration, is of course the patient willing for the other eye surgery, which can be a challenge. Choose the appropriate surgery. We can see that there is a graded response to various kinds of surgeries. I use lateral rectus to medial side, especially in associated vertical deviations. The medial periosteal fixation is like a fail-safe surgery for me. So I've done it in probably all kinds of residual surgeries, including lateral rectus to medial rectus, failed LR to MR transpositions, if the FDT is tight and you have large residuals. So thank you very much for the opportunity.
Yeah, wonderful talk, Dr. Rohit. I think when the problem becomes big, you have to plan powerful procedures. So very well highlighted all the surgeries. And I think preoperative counseling is very, very important for planning surgery on the other eye or planning multiple procedures that these might be needed. Vivek, you want to add anything?
Yeah, so I think wonderful, the panorama of different surgical procedures, and that too, for third nerve, because third nerve is one of the most difficult entity, to treat, to make these eyes straight, especially, those with congenital third nerves. Acquired most of the time, as he talked about, there would be kind of a partial recovery. So whatever the rest of the amount we can always deal, and we do have a lot of option. But as he said, like, you know, transposition of lateral rectus, you have to be extremely careful on table FDT. So if LR is super tight, do not do LR transposition or do not split it and try to bring, it will never go to the MR. So that's very, very important. So you need to choose on table, then probably, you know, like periosteal fixation or LR recession with medial rectus, you know, the globe, as he has shown that particular surgery. So I think these are the decisions which are very, very important, because on a preoperative evaluation, you might get tempted, you know, like, yes, there is a complete, you know, the medial rectus adduction limitation, and probably I would choose, but then there is a second check on table FDT that will take you a call for, you know, whether to do the LR Y split and transposition. Second thing what I wanted to add was, you know, the transposition of entire LR to the MR. So when there is a hypertropia, you need to transpose inferiorly, and when there is a hypotropia, you need to transpose superiorly. And while doing transposition, particularly the Y split, I think knocking out both the obliques is very much logical, being, you know, they are abductors, so that would add some effect to your transposition. And he has already mentioned, like, giving a fixation suture that adds more adduction effect to your transposition.
Yeah. Thanks, Vivek. And I think it was important to realize that how many modifications Dr. Rohit highlighted during the talk based on the patient findings. Avipsa, you wanted to ask quickly, or?
Just one question. When we are using fixation duration, then we are going for the primary deviation in the other eye. Because you said that a little more
Yes.
has to be done.
Yeah, so we are so if you have a paralytic squint in one eye, your surgical nomogram is more than what you would have conventionally planned for that deviation. So I see, essentially what I'm saying is, even though we are operating the normal eye, our amount of surgery remains the same, because the end effect that we require is much larger than your conventional. So sometimes the thought goes that we are now operating the normal muscle, so I would do the normal amount of surgery. I mean, like we've talked about 8 mm lateral rectus or 9 mm or 12 mm lateral rectus recessions or 9 mm medial rectus resections, which are not our normal conventional nomograms for comitant surgery. But if I am doing a fixation durus, I'll have to do that much surgery in the normal eye, because I need to get that much higher innervation to the affected muscle. So normally, otherwise you would have thought that I don't do 9 mm in a normal muscle, but in this case we will have to, because of the creation of the fixation durus.
So otherwise it would not give the good effect in the affected eye.